Welcome to the July edition of the European Urology Podcast. My name is Declan Murphy, urologist here in Melbourne, and I'm joined by my co-host, Dr Nikita Bhatt, who's the urology fellow in Newcastle in the UK, in the sweltering UK as we speak here at the end of June. Nikita, how are you?
I am boiling hot. It's really warm right now, but can't complain. You get about 2 days of sunshine in the year, so yeah, we'll take it. But yeah, I'm good otherwise. We had a really busy bout this week, so just still recovering from that, but otherwise doing well.
Yeah, I saw some nice tweets. Bouse looked very successful, big numbers, 1,300 people, etc. It looked like a cracking meeting. And did I see, were you out for a run? You were on that fun run?
Yes, a big mistake. I'm not a runner, but the Urology Foundation does amazing work for BURST, which is a collaborative I'm part of, and has funded our studies and also sponsored my traveling fellowship to the US. So I felt like I needed to support the charity. So I ran and suffered, but I did it.
Well done and tough. The Urology Foundation support fellowships down here to Australia. Many of our fellows at Peter Mac have been supported by Tough as well. So I'm very happy that you went out and did a run and helped support Tough. So well done to you. And yes, stay cool. It is very hot in the UK. So that's good. If I'm speaking here from midwinter in Melbourne, it's not very hot. So now the other big news this last week, apart from Bouse and heatwave in the UK, was the impact factors came out. And I know you've been looking at these, but it's always exciting this time of the year. All the editorial teams and especially the editors-in-chief of all the big urology journals around the world who pretend that the impact factors don't matter. But I tell you, this time of the year, they're all frantically waiting for the journal impact factors to come out. So yeah, what's your take on it? What were the headlines on the impact factors from European urology point of view, Nikita?
I think we've had a really successful year as usual, and it's great to see that European Urology maintains its impact factor at 25.2. Really good to see that the hard work pays off, at this time of the year, like you say, but also really good to see that the family of European Urology journals is doing really well, and there's an upgrade in the impact factor in a couple of our journals, so that's always encouraging to see. So do submit to all our other sort of family journals as well that are doing really, really well.
Yes, I'll call them out while we're at it. Congrats to Alberto Briganti, of course, our editor-in-chief of the main journal. European Urology remains the highest ranked journal in urology, impact factor 25.2. European Urology Focus, which Christian Gratzky has been editor-in-chief of for many years, has increased its impact factor from 4.9 to 5.6. So it's breaking through the 5, which is always a good psychological thing. Well done, Christian and team. European Urology Oncology has risen from 8.3 to 9.3, led by Morgan Rupre, who took over from Briganti when Briganti moved to European Urology. So that's going to crack the 10 before you know it. Hopefully Morgan and team can do that. And finally, European Urology Open Science, led by Jochen Waltz, has increased from 3.2 to 4.5. Bearing in mind, I think that this might be only its second year or maybe third year of having an impact factor. So it's going gangbusters. And that's our open access journal. And it gets huge numbers of downloads on all those articles. Open access is great. So they're all very happy with themselves. The editors-in-chief have a job for another year or so to come. So well done to everybody. But yeah, onto the July edition. Nikita, I have to credit you with having selected our two big papers this month. The first one is longitudinal evaluation of clear cell renal cell cancer in VHL from the National Cancer Institute, the NIH in the US, led by the legendary Marston Linehan, who's the first author on this paper. It's pretty much his kind of personal series of VHL going back over a 20-odd year period. And he, of course, who has dedicated his life to the genetics of renal cell carcinoma, and he and his team fundamentally discovered the genetic pathway and the therapeutic options now for VHL. So this is a really, really interesting paper. It's kind of a landmark paper on the natural history of VHL. So thank you for picking that one. And the other paper you picked out for the highlights is this systematic review of novel intravesical approaches for patients with non-muscle invasive bladder cancer. So that's kind of a busy space, Nikita. This review caught your eye for good reasons, I'm sure.
Yeah, absolutely. Yeah, great. The renal cancer paper is really interesting, even though don't deal with renal cancer that much, but I found the paper really good in a sort of disease area that didn't have much previously. And about the bladder cancer, as you know, I kind of partly do bladder cancer, so it's something that always interests me. And it's really frustrating when you see patients in clinic that don't respond to BCG and don't want a cystectomy, and you've got nothing else left. So I'm very excited to see what's going on in this field. People have been busy. That's an understatement. If you read that article, there's so many single arm studies in this space now. Very, very exciting.
Yeah, and for trainees out there, yeah, this is the one, go and grab this one, and that's it. That's your reference for a really good, timely review of these agents. So that's coming up later in the podcast. And then finally, after that, we have Eoin Dinneen, Dr. Eoin Dinneen, one of our fellows here in Melbourne, who's going to do a quick overview of 3 other papers that caught his eye in the journal this month, and Eoin will be into the studio to do that. So let's first of all go to my chat with Dr. Marston Linehan about VHL. So for our first paper on the European Urology Podcast this month, we've highlighted a really monumental series of VHL patients from NIH, from Dr. Marston Linehan and colleagues, and they've published it in this month's edition of European Urology. It's a fascinating insight into the natural history of what these VHL patients can experience, and really a huge series by global standards, and some very interesting observations of the sort of outcomes these patients have in terms of growth of lesions, intervention for lesions, and outcomes, and so on. So the full paper is linked in the show notes, but it gives me a great pleasure, really, to welcome first author Dr. Marston Linehan, the Chief of Urologic Oncology at the NIH in Bethesda, to talk to us about his paper. Dr. Linehan, welcome, and thank you very much for joining us on the European Urology Podcast.
Thank you, Professor Murphy. I'm happy to be here. Thank you.
Well, great. And look, first of all, congratulations on this paper. Now, obviously, you've published a lot of papers in your distinguished career, but I think this one for you personally, describing this huge series of well over 200 patients over a very long period, must be something special, because it's pretty much your own personal series at the NIH. So tell us a little bit about that, about your distinguished career of looking after these patients and all the discoveries you and your team have made about the genetics of renal cell carcinoma, before we dive into this particular paper.
Well, thank you. Thank you very much. We started looking at kidney cancer. We started out by trying to find the gene for kidney cancer. There were no genes at the time. Our first gene was the one for this disease, VHL. We're now up, if you can believe this, we're now up to 19 genes for kidney cancer. It's just incredible to me. We now know there are 16 different types of kidney cancer that run in families. And of course, what this paper is about is our experience with von Hippel-Lindau, VHL, which is, of course, the most well-known type of hereditary kidney cancer. And what we wanted to do in this paper, really, is something we hadn't done before, and that was look at a group of patients. And in this case, we took 244 patients with VHL who had, all of these patients had kidney cancer, and all of them had a kidney cancer that was at least 1 centimeter in size. And then we looked at those patients, we looked at their outcomes, their radiographic outcomes, their renal surgeries, their metastasis, sequelae to surgery between 2004 and 2020. And what we found was really surprising to me, I must say. You take care of patients every day, and you do surgeries, you see them in the clinic, you do this, and sometimes you might miss the big picture. And I must say, I personally sort of did over the years. And these patients, we knew that the kidney cancer was a morbid characteristic of VHL, and of these patients, 186 of the 244 had 1 or more surgeries during this time period. 108 of them had 2 or more surgeries. And what we found, and sort of the main finding in a funny way, is is what we found was that 41% of these patients developed chronic kidney disease during the course of this study. And I must say, I kind of miss that. I mean, of course, we see it in a patient, and you bring them back after surgery, and their creatinine's up a bit, but it comes back down and all. But over the course of this, 41% developed CKD. I was really surprised. We had 12% developed metastasis, and of course, that's why we manage these people so carefully to prevent that. But even with a very experienced team over the years, that's what we saw.
Well, it's extraordinary to hear you with that observation, with your own personal experience of looking after VHL, because it's still a pretty rare condition in general urology practice, I suppose. And working in a large cancer center like I do, we have a well-defined proportion of VHL patients. And I suppose that is the best way to manage them, is try and concentrate them in a center where they are having a little bit more surveillance. They got multidisciplinary approaches and they're following protocols. Right. But for you to observe that it surprised you about that incidence of CKD it is quite remarkable. And that speaks to the importance of the paper, I think, really, Dr. Linehan, is that when you step back and look at a few hundred of these patients over a 15, 18-year period, you do get struck by these observations. And a question I was going to ask you about that is that, predominantly this is an era when those patients were having surgery for their renal masses, including partial nephrectomy and nephrectomies, a lot of nephrectomies, I suppose. These are exactly kidneys that have lots of tumors in them, or they've been intervened on before. But in the recent years, with other ablative treatments, heating or cooling of lesions, or even now stereotactic radiotherapy, I'm sure that's being embraced in your practice at NIH. Do you think in 20 years' time that might lead to maybe less CKD, or is it just a natural history thing? These kidney tumors need some intervention. There's going to be some CKD.
Well, that's a very good point. And we tried early on, about 2000. We started in the late 1990s, and 2003, 2004, 2005, to do. We started off. Oh my word! In the 80s, when we first saw them, what our field recommended was nephrectomy, and I'll never forget. I did a bilateral nephrectomy on a patient with VHL in the early 80s. That's what, was the training in our field. We had publications in the Journal of Urology saying that's how you manage these. And I'll never forget it as long as I live. I took that patient downstairs. I put him in a taxi cab and drove to the airport to go home and get dialysis. And I said, I'm never doing this again. They can fire me if they want. But so we started doing, in the middle 1980s, we started doing partial nephrectomies in these patients, and we'd operate on them. And then they'd come back, and we'd see more tumors. We'd reoperate, and I'll never forget. How you remember cases? I'll never forget a case I was doing with one of the surgical fellows. I can still remember exactly the case. And I said to this guy, I said, we're going to have to start putting zippers in these people. My word, we're operating on these people so much. Well, so then we started to do active surveillance, and I must say we got a lot of criticism for that. People said, you've been at NIH too long. What are you all doing? That's not the way you manage surgery. We operate on it. But we developed an approach to do active surveillance until the largest tumor reached 3 centimeters, at which time we recommend surgical intervention. And, as a surgeon, I'm like all surgeons, I'm superstitious. So I don't want to say this too loud, but as of the 20th of June, 2025, as of this day, we have not yet had one patient, not one, develop metastatic disease when managed in this fashion, i.e. the largest tumor is 3 centimeters, we recommend surgical intervention. We have had some that developed metastasis, but they all came with larger tumors. So we started doing that, and watching these people carefully and doing partial nephrectomies whenever we could. And then we said, gee, why not? Just as you suggest, why not do RFA or ablation of some sort, cryotherapy? And we did that in nearly 120 patients with kidney tumors. But we didn't really like it for these kinds of patients very much, who have VHL, who are at risk for multiple tumors and are at risk for multiple recurrent surgeries in the future. And of this group, a large percentage had 2 or more surgeries. And so we know in our experience that RFA can make the repeat surgeries more difficult. So we really don't like, in general, to do RFA cryotherapy in these. We will when it's kind of a last resort, but we find it to make it a little difficult to follow those tumors. We're going to follow them over years. Also, we think it complicates our further surgery. So another reason we did this study was because, as you know now, there's a drug approved, belzutifan, approved for treatment of patients with this disorder. And we also, how do you know your drug is working if you're using a drug? I mean, so that's one of the other reasons we did this study, to say, look, a natural history study of patients, carefully managed, what was the outcome. And as I mentioned, the kidney cancer had more morbidity than I thought. We were usually kind of going, yeah, we don't have metastatic disease, very infrequently, but we managed appropriately. But the CKD, I must admit, kind of crept up on me, and that is a bad prognostic indicator, CKD. As far as decreasing life expectancy, increased incidence of heart disease, etc. So we think it's an important message to get out there.
And you hinted at the use of belzutifan. So this has been a sensational development really for VHL patients, thanks to this pioneering work you and your colleagues have done, defining the genetics and therefore giving us a target for these drugs. So I think the current approval for belzutifan is for patients who have biopsy-proven disease and they've had an intervention, and the idea then is that it may stabilize them, so it reduces recurrence and progression. Or is that the scenario that you're using belzutifan at present?
Well, yes. In the U.S., it's approved for patients who have von Hippel-Lindau, who have VHL, not necessarily the biopsies, in other words. And patients in the U.S., the FDA approved it for kidney tumors, pancreas tumors, brain and spine tumors. There's dramatic response in the eye tumors as well, but it's not yet approved for that in the U.S. anyway. And so it's approved for people who don't need imminent surgery. In other words, our sense is if somebody's got a fast-growing tumor, large tumor, our sense is the most appropriate thing to do there is go ahead and do the surgery. But it's approved for people, with a renal tumor, pancreas tumor, or brain tumor.
So if you have a patient who's had their first surgery for a 3-centimeter tumor, and they have other small lesions you'd be watching, is that the patient for belzutifan then? Is it?
Absolutely. Absolutely. Yeah. We have, in our most recent data that was presented this last weekend, as a matter of fact, at ASCO in Chicago, we have a 70% response in kidney tumors and a 28% stability. So like 99% of the tumors either respond, resist response, which is 30% regression, and in those tumors. In the kidneys, the pancreas response is 91% with a 65% complete response. And the brain tumors and spine tumors, about a 50% response. So we think it's a real advance for the management of these patients.
And then finally, I suppose, having said that, you must have great optimism that the next 250 odd patients who come through NIH and who have access to drugs like belzutifan, hopefully they'll have less intervention or less frequent intervention, and your shock or surprise at seeing this incidence of CKD that you report in the paper of 40% after surgeries will drop, hopefully, because it should be an optimistic outlook for those patients, I hope, Dr. Linehan.
Absolutely. There's a huge difference. If you look in the patients that were treated with belzutifan on this study, a very large, there's a very large number. If you look at the 4 years before they started therapy, a very large number of surgeries. And then if you look at the number of surgeries in the 4 years since they started belzutifan, it's a huge drop-off in the number of surgeries. Absolutely.
Fantastic.
And when you think, and we both know this, when you think of the morbidity of these patients, we've taken out in a single operation more than 50 tumors from a single kidney in a VHL patient over the years. And when you think of the morbidity of those operations, the blood loss, the kidney function loss, and the pain and suffering of these wonderful, brave patients that we have the honor to work with, and then you think about an agent that may significantly decrease the need for surgery in those patients. Yeah, we're very, very optimistic and hopeful about that. And another thing, we hope for the future, hadn't been dead yet, but would be a study to look at this as a prevention of this disorder. We'll see. This drug targets the main pathway in VHL, which we and others identified in 2002, HIF2, and the HIF2 drugs. So would this be a good prevention? Well, we'll have to see. But it certainly decreases the number of surgeries that patients need, and we're very, very excited and optimistic about that, and hopeful for the future.
Well, huge congratulations again on this paper, but also on your entire career dedicated to uncovering the genetics of renal cancer. It's been a great privilege to speak to you on the European Urology Podcast today, Dr. Linehan. Thank you so much. Thank
you very much.
Wow, that was an amazing interview, Declan. I can see that you're quite starstruck there, and really nice conversation, really nice paper. And what did you think of Dr. Linehan there?
I was a bit starstruck, I have to say. I mean, I've been around for a few years in GU oncology. Nikita, I know lots of people, but I never met him before, Dr. Linehan, and he's always been an incredibly godlike figure in the world of renal cell genetics, since I was doing the FRCS Ural and he was doing all these discoveries. But he's the nicest, most modest person I think I've spoken to on a podcast in a while. And his personal interest in that series of patients comes through in this paper and in everything he does when he speaks about VHL. And so I really, really enjoyed speaking to him. And in fact, I spoke to him afterwards and asked him would he come on GUcast for a kind of a longer chat about the whole genetics of renal cell cancer, because it's fast moving. It went from 0 to, he told us, 16 or 17 genes, and him and his collaborators have been involved in almost all of them. So I am going to reach out to him again and see will he come on GUcast. He kindly indicated he would. But it was a great chat, and it's a really, really good paper. And again, for people, especially who are preparing for exams or anything like that this is a really, really important and easy read summary of what it's like to be a VHL patient and what your patients can expect if they've got VHL. And thankfully, as he spoke about at the end, that very cheery outlook with the advent of drugs like belzutifan, that will significantly modify the behavior of these cancers, hopefully, for these patients. So, yeah, but thank you for pointing out. I was a bit starstruck. I really, really enjoyed that chat.
For good reason.
Indeed. So we better go to your chat, though, with Saum Ghodoussipour and team who've put together this beautiful systematic review of novel intravesical approaches for non-muscle invasive bladder cancer.
So I'd now like to welcome Dr. Saum Ghodoussipour, who works in New Jersey, and we're discussing his paper that was published this month. It's the systematic review of novel intravesical approaches for the treatment of patients with non-muscle invasive bladder cancer. Many congratulations, Saum, and very welcome to the podcast.
Thank you so much. It's a true pleasure to be here.
Can I ask you to briefly summarize the findings of your paper and just tell us why we should go and read this paper?
Yeah, well, yes, I'm very happy to. So, this paper, as you mentioned, is a systematic review of novel intravesical approaches in non-muscle invasive bladder cancer. In my very biased opinion, I think this is one of the most exciting spaces in our field right now. I think we all know, how prevalent and how much of a public health issue bladder cancer is. But because of the recurrence rates, progression rates, and the cost of bladder cancer, there's been a lot of interest in developing new treatments to sort of, either supplement or replace BCG or single agent chemotherapy, which has been around for decades. So for a lot of reasons, including, the FDA's recommendations in the US to have single-arm trials for BCG unresponsive disease, there's been a boom in research in this space and a number of clinical trials and new agents, either on the market or in research. So we sought to sort of summarize that. And in our review, we found almost 3,000 articles that we skimmed through to include only clinical trials that have been published in this space. And we found 36 of those trials that reported on safety and efficacy. We also looked into some novel outcomes, which, I'm sure we'll talk about, or not necessarily novel outcomes, but important outcomes like patient-reported outcomes. And we sort of tabulated and summarized all of those. And what we found were, or summarized, were all the different approaches, which are pretty diverse. So there is BCG based therapy. So that's using standard BCG, but adding novel therapies to that, combinations of chemotherapy, chemical drug conjugates, including thermogels, hyperthermic chemotherapy, which is been studied for a while in the EU. But we also talked about osmotic pumps and gene therapies, all of which I think are really exciting. And basically the gist of it is that they were all, rather effective with low toxicity, which is great. But a lot of heterogeneity in the way these agents have been studied, not a lot of comparative data, unfortunately, and some of the outcome measures are still lacking. But we sort of tried to put this all on paper as a useful reference for urologists.
Wow, that's a lot of hard work there, and really good to see such an explosion of, intravesical agents. Like you say, this is a really exciting area. And from your kind of research, what do you think say a couple of agents that you see coming into clinical practice across the world, or specifically in the US, in the next 5 years?
Yeah, so I'm honestly excited about all of them. I can nerd out about all of them, but in the US, we're actually fortunate to have several of these agents approved and on formulary at our centers right now. And in the paper, we sort of run through those agents and how they have been approved. I think that we're not quite there yet in the EU because the EMA wants to see randomized controlled trials, but starting off with BCG and what we can add to BCG to augment its efficacy or to avoid sort of the escape mechanisms for resistance. There's some exciting research combining BCG with checkpoint inhibitors. And in our paper, we talk about all the early trials that are using different agents in that space. This would be standard intravenous checkpoint inhibitors with, pembrolizumab, atezolizumab, durvalumab. But there have also been a lot of exciting approaches to try to change the delivery mechanism of the checkpoint inhibitors to try to decrease toxicity, including intravesical instillation of checkpoint inhibitors, intravesical injection, so subepithelial injection of these checkpoint inhibitors. And then there was a phase 3 trial that just recently reported using sasanlimab, which is a subcutaneous injection of a checkpoint inhibitor. So if you look into the paper, we go over all the results and the different tolerability of those agents. But beyond that, there's other ways to augment BCG's activity. Anktiva, or N803, is something that's approved in the US, which we have available to us. This is an IL-15 superagonist that's given with BCG, and I believe it's under review by the EMA as well. So those are the exciting combinations with BCG. With chemotherapies, in the US, we use gemcitabine and docetaxel almost as a standard of care for patients with BCG unresponsive disease. And one of the biggest criticisms of it is that there is not yet a lot of published prospective data. The retrospective data is very good. It's very convincing, but in fact, there has been a phase 2 trial published in the BCG naive space, which we highlight in our paper, and some ongoing large-scale trials, namely the Bridge trial, which is randomizing patients to BCG versus gemdosi. And then from there, we talk about thermogels. I'm very excited about this, and we just had another FDA-approved agent, UGN-102, also known as Zasturi, which is mitomycin in a gel formulation. These gels are instilled into the bladder, and they sort of last for a long time to sort of have contact with the tumors. And then the gene therapies are super exciting. So 2 agents approved in the US. Adstiladrin and cretostimogene is, not approved yet, but has some convincing data, and I think it's on its way. And then finally, we talk about device-assisted therapies. So this is the TAR system, which are these semi-permeable silicone tubes that slowly release different agents into the bladder. And those are very exciting, with some great outcomes so far, which we sort of summarize in the paper as well.
Amazing. So let's talk a little bit about the study population. So, I mean, the paper does say it's non-muscle invasive bladder cancer, but while going through it, I spotted a couple of trials studies that were looking at sort of muscle invasive bladder cancer. And then within the non-muscle invasive, there were some that were low grade and high grade, some CIS. So how do you think the heterogeneity of the population affects the outcomes in this area?
Well, I think that we do have to look at the different subgroups of non-muscle invasive bladder cancer differently. Low-grade disease has very different biology than high-grade disease. High-grade disease does have that potential to spread outside of the bladder and potentially be lethal, versus low-grade tumors we think behave very differently. But recurrences are a very problematic issue for patients. It requires TURBTs, which can impact their quality of life. The surveillance intensity, it's invasive to have a cystoscopy. So there's different reasons to study the different disease spaces. But what we tried to do in this review was to sort of summarize all the agents and all the different ways that they're being tested and developed. The BCG unresponsive space, which is the most challenging in terms of, potential for progression and lethality, is where all these agents sort of have been started in terms of their research. And that sort of comes from that FDA guidance, at least in the US, to do single-arm trials. But as those agents get tested in the BCG unresponsive space, they're moving to the BCG exposed space, where patients have had just 1 round of BCG and standard of care would be to give another. But patients are aware now that there's other agents being tested. They know that their success rate's not going to be that high. They want another option. So it's really important to test these agents in that space as well. And then intermediate risk disease, like I said, is a totally different space. And now people are using these agents in muscle invasive disease. For example, that TAR system that I talked about has been studied in muscle invasive patients who are getting chemoradiation and patients who are going to get cystectomy as a neoadjuvant therapy. It sort of makes sense that if you treat the bladder, you could potentially, affect the staging in the bladder, but there might be some local spread, to the pelvic area where that micrometastatic disease can happen.
Yeah, absolutely. That's very interesting. And I guess watch the space to see where we can go with these agents. And then in terms of study design, like you've mentioned a couple of times about single arm studies, are there sort of any plans to have head-to-head comparative RCTs between different agents, or like a MAMS study design, for example, because there's so many of them? What would you like to see in this space, considering you've got so much knowledge about these agents?
Yeah, I think the whole MAMS multi-arm, multi-stage design is exciting. Everyone wants to have the next Stampede, And I think that is on the horizon in this space as well. And I think that we would all be very excited to do that. But I don't know if we're quite, I mean, I think we're ready to do that right now, but I'd like to wait for a few more of these agents to get approval. This FDA recommendation to do these single-arm trials has been a great thing, right? It's led to a lot of innovation, a lot of industry partnership in our field to develop new drugs in a space where, 10 years ago we didn't have options for patients with BCG unresponsive disease. I'm saying, I know that the US and Europe are a little bit different in what we can offer these patients, but it's exciting now. Since 2020, we've had Adstiladrin, which is the adenoviral vector, approved, and that delivers interferon alpha to the tumor cells, so it works via an immune-mediated mechanism. We've had BCG plus Anktiva, which is that IL-15 superagonist. We just had the chemotherapy Ghodoussipour approved for patients with low-grade intermediate risk disease, and that's a chemotherapy agent, a chemoablative agent. Cretostimogene has very promising results. I think that approval is on the horizon as well. That's an oncolytic adenovirus. So in addition to stimulating the immune system via introduction of GM-CSF into the cells, it also has some oncolytic properties attacking retinoblastoma deficient, pathway deficient cells via the E2F promoter. And then we've got TAR, which is sustained release of chemotherapy. So in the next year or two, we're going to have several immune-mediated and cytotoxic or chemotherapeutic agents approved. And we're going to have patients come to our office, and we're going to have to run through all these options and help them make a decision. And right now, we don't really have any data on sequencing. We don't have any data on comparison with these agents. And we tried really hard in our paper to not compare the agents because I just don't think it's fair. It's not apples to apples to compare these trials to each other. So that is the next step to do that. But it's going to, as you can imagine, it's going to be hard for our industry partners to want to put their drug up head to head with another one. So I think it's going to be on us, probably through our cooperative groups. In the US, there's several large cooperative groups. In Europe, there is as well. And once we have some randomized controlled trials in this space, we can start to have global approvals rather than just, US or FDA approvals.
Yeah, absolutely. And so I suppose just looking at the outcomes in these studies as well, if you're planning a trial, like you say, there were I think about 6 studies that looked at PROMs, which obviously I would imagine with BCG having a lot of side effects and patients not being able to tolerate maintenance therapy, I would imagine that's really important. So what would your comment be on someone who would say be designing such a trial about PROMs?
I think we've smartened up in the last few years, but not just in the bladder cancer space, but in all of our field, all of urology, to look at things from the patient perspective and include some outcomes that are very relevant to patients. Like you said, all these trials, they sort of report efficacy and tolerability, and efficacy has been reported as complete response rates, which I think is a very valid outcome in patients with especially carcinoma in situ of the bladder. But when patients come in and they hear that they have a certain complete response rate at their first assessment, they want to know how they're going to be doing at a year. So they want to know about the durability, or a year or 2 years, to be honest, or even 5. So they want to know about the durability of their treatment and maybe some meaningful outcomes, things like cystectomy-free survival. We report that in our paper, the studies that mention that. That's an important outcome to patients. And then, the quality of life is important. These patients are coming in sometimes once weekly for treatments that can irritate the bladder. But there are some of these novel agents that have treatment sequences, which is just once every 3 months. And you can imagine that's very patient-friendly. So we could be objective and quantify how patient-friendly that is by having some good patient-reported outcome measures. So I think that's definitely in the future. It's where we've been lacking. Only 6 of these trials, like I said, had a patient-reported outcome. But tolerability is important, but that means different things to a lot of different people.
Absolutely. Yeah, I think that those are all the questions I had. I think this is a really good piece of work and certainly lays the foundation for any trial in the future. I imagine this will be cited a lot with future trials coming up. So congratulations again on your paper, and I hope our readers enjoy reading it. And there's some lovely diagrams in there as well, might I add. So really well done.
Yeah, we're very proud of the pictures, and so yeah, take a look and check it out.
Great. Thank you so much.
Excellent review, Nikita. That was a wonderful chat with Saum. And a lot going on in intravesical stuff in the bladder. It used to be just a bit of mitomycin and a bit of BCG, and then back to BCG and back to mitomycin. But excellent systematic review, and the link is in the show notes. That was a good chat.
Yeah, an absolute explosion of intravesical agents there, and hopefully we'll see a few of these in clinical practice soon enough.
Yeah, and this is a great reference, so it's in the show notes. So any of you trainees out there trying to get your heads around all the different things you can stick in the bladder, just look up Saum's paper in the show notes. So that brings us to our wrap-up section. Eoin Dinneen has joined us in the studio. Eoin, welcome.
Thank you.
It's kind of a regular slot for Eoin now for the next, how long more are you going to be in Melbourne?
18 months.
18 months. So Eoin will be, she says, Eoin will be, he'll be anchoring this part of the podcast where we try and see what else is going on in European Urology this month. So I know there's so much going on, and you texted us during the week, say, can I highlight 5 papers? And we said, no, the rule is 3 quick ones, and we'll put the links in the show notes. So there are a lot, aren't there? But tell us the 3 you found, Eoin.
3, 1 past, 1 present, 1 future. So we're going to go in that order. The number 1 is increasing life expectancy in patients with genitourinary malignancies, impact of treatment burden on disease management and quality of life. The authors are an eminent international collaboration, including Marie-Pierre Saint-Laurent from University of British Columbia, James Cato, former editor-in-chief of European Urology, is amongst the authors, and Sarah Psutka is the senior and corresponding author from the University of Washington in Seattle.
Who's one of our associate editors, yeah.
The plot thickens. Narrative review article. It's long at 7 pages. And essentially the crux of this is that many of us are familiar with increasing prevalence in GU malignancies as life expectancy increases. It puts a number on that. From 1990 to 2019, age standardized incidence of rates of bladder cancer have gone up by 4%, prostate by 22%, and kidney by 29%. Alongside the increasing incidence and the life expectancy with some of these, it introduces this critical concept of treatment burden. So it's the determinant of quality of life, referring to the workload of receiving care and its impact on patients' functioning and well-being. In other words, the time and the toll and the cost, the financial toxicity of managing their GU cancer and its impact. So I think it's nice because leading oncology journals and indeed European Urology will focus on the hard oncological endpoints, and we've seen improvements in life expectancy on all the big 3 cancers. For instance, neoadjuvant chemotherapy in bladder cancer, such as EV, also increasing overall survival by 15.4 months in bladder cancer, prostate cancer mortality rates on slow decline, with things like docetaxel and the ARPs, and kidney cancer as well. So there's a lot of good stuff going on. So more patients with GU malignancies are living for longer, but are they living better? And that's the crux of this article. And actually, it's a hard question to try and get a grip of, because many of these oncological articles and journals will be stuffed full of data, but the patient-reported outcome measures will be in there sometimes, or perhaps referred to in various ways by calling it toxicity and stuff like that. So the answer to whether patients are living better is hampered somewhat by lack of and heterogeneous reporting of quality of life measures in oncology papers, and perhaps a lack of sensitivity of routinely used patient-reported outcome measures for some of these harder to grasp quality of life measures themselves. So authors make some recommendations and also point out that in the holy grail will be kind of goal-aligned, patient-centered decision-making. And for goal alignment, we also kind of need to know what the implications for treatment burden and quality of life, alongside some well-characterized survival improvements, will be for some of these new strategies. Yeah. So it's nice. It's long. It's a bit of a deep read, but I think if nothing else, it gives you a really nice overview of some of the overall survival advantages that we've seen in the big three GU malignancies over the last 20 years.
And Sarah's had a long interest in this as well. It is, it's wonderful on the one hand that patients are living longer, and they certainly are when you look across the board. But are they living better is always the question. And what's the cost of it as well? And I think that's why it does flow into discussions about endpoints and meaningful endpoints. And, the pharmaceutical industry understandably has to have a return. And, they are at the big oncology meeting celebrating endpoints that are not overall survival. They're not proving at this point in time that patients are living longer. And I think that's why very often you'll see someone's going to read out a RPFS endpoint or a DFS endpoint for adjuvant therapies, and we'll go, well, we better hang on until we actually, get overall survival. Not just for the health economics of it, but you don't want to be exposing patients to treatment burden unless they're going to at least live longer and hopefully live better. So I don't know. It's very reflective, Nikita, isn't it?
Yeah, I think Owen's point about PROMs is so important, and we discussed this last month for PURE as well, for stones, and in the last paper about bladder cancer intravesical treatment. There's very few papers, especially in oncology, looking at PROMs, and I think especially in this age group, it's so important because it's not only about prolonging life, but also adding to the quality of life. And if you're not doing that, then we really need to rethink what we do to our patients.
Excellent. Well, I haven't read that paper, but I'm going to read that paper, Owen. So thank you for drawing it to our attention. What's next? Paper number 2.
Okay, number 2. This is kind of the present, if we're going through the theme. And really nicely, I think it draws in 2 other things that we're also covering in this podcast. Firstly, so the setting here is advanced and metastatic clear cell renal cell carcinoma, and I'm going to refer in a moment to slowly declining age standardized mortality in that cancer group, which this patient, this article kind of is in that setting. But also we host Marston Linehan on this podcast, talking about belzutifan, talking about von Hippel-Lindau disease, and indeed this is all about belzutifan as well. So there's a nice mix and kind of melting pot of that particular theme here. Yep. So this is also a editorial. It's very short, so it's a quick read. First author is Catherine Graham, and the senior author is Tom Powles of the Bart's Cancer Institute, a member of the Time 100 Health Most Important People in the World. Clear cell renal cell carcinoma, which by the way has seen an age standardized mortality decrease from 2019 of 2.08 per 100,000 people to 1.5 in 3 years later in 2022, partly due to some of the work reported in this editorial by Tom Powles and the work that he's pioneered with his colleagues. Marston Linehan outlined for us a little bit of the molecular setting of von Hippel-Lindau disease and von Hippel-Lindau gene, which is a tumor suppressor protein that regulates hypoxia-inducible factor 2 degradation. So in VHL loss, such as patients with VHL, HIF2 upregulates genes that promotes angiogenesis, cell proliferation, and clear cell renal cell carcinoma. So HIF2 or hypoxia-inducible factor 2 inhibition would be an attractive target for RCC, and that's exactly what belzutifan is. In August 2021, it was licensed by the FDA for use in adults with von Hippel-Lindau disease, requiring therapy for associated tumors, namely the clear cell RCCs, CNS, hemangioblastomas, pancreas, neuroendocrine tumors, and that was based on the LightSpark 004 study. Later, LightSpark 005 was a successor study that looked at belzutifan in advanced, spontaneously occurring clear cell renal cell carcinoma and compared it to everolimus in patients who had progressed through 1 to 3 previous systemic treatments for their metastatic clear cell carcinoma. So this article is a little bit about differences in regulatory approvals for use of belzutifan in America versus Europe. I think it's nice because it also ties into some of the conversations that we've clearly been having about overall survival versus progression-free survival versus the patient-reported outcome measures and the toxicity of these treatments. They point out that it's not quite recommended on the same level in Europe as it is in America, but they also point out that it's not yet been demonstrated in metastatic or advanced clear cell spontaneously occurring renal cell carcinoma to have the overall survival advantage. So for me, the comment on this, aside from the detail of reading the article and the twos and throws of the regulatory approvals, is that clearly in this setting for clear cell renal cell carcinoma in advanced and metastatic setting, the pace of change is clearly quite exhilarating, and it's probably partly why we're seeing some of the improvements in overall survival. And also this article alludes briefly at the end to moving forward belzutifan earlier and in combination with some other molecular targeting drugs earlier in the patient pathway for patients with clear cell renal cell carcinoma. So watch this space perhaps for further improvements in overall survival or substantial oncological outcomes on that front as well.
Nice summary. And it is important that urologists or anyone involved in early renal cell cancer with VHL patients knows about belzutifan, because it is really, really big news. And one of our patients here 2 years ago or 3 years ago, after the FDA approved it in 2021, and it wasn't approved here, he moved to the US so he could get access to belzutifan, so he could self-fund it himself over there. He'd already had one partial nephrectomy. And as we heard from Marston Linehan earlier, you know, the burden of VHL over the following many years for these patients is very, very high. So if you have an intervention that's going to reduce your interventions, it means less likelihood you're going to have CKD and so on and so forth. So he moved over there. It is now approved here in Australia for the last couple of years, and we have an access program for patients while we wait full reimbursement. But it is important out there. It's only an editorial, as you say, but if you're working in kidney cancer and you want a little summary of VHL and belzutifan, European Urology July 2025 is a great one for you. You've got Marston Linehan's natural history paper describing over 200 patients, and then you've got this lovely summary of the current status of belzutifan from Tom Powell's and team at Bart's. Yeah.
And I think it takes you from the molecular setting all the way through from bench to bedside via the regulatory approvals, which is of course really important for getting patients the access to these like incredible new medications.
Are you interested in this topic, Nikita?
Not really, but it's fascinating all the same to see medicine move forward and have options for patients that previously didn't. So very interesting.
Is. And also for trainees out there, because VHL is one of those classic things when you're studying for the FRCS Urol or European exam, it's very important to understand the genetics of kidney cancer, but especially VHL. So yeah. Very good. One more. What have you got? Okay,
so first of all, I'd like to apologise because I realise I've not done 3 articles in 3 minutes. I'm way over time here, but we're moving forward, and we move to the future of the past, present, and here's the future. So artificial intelligence in prostate cancer diagnosis on MRI imaging, time for a new paradigm. The authors are from London, including my former boss and supervisor, Professor Viru Kasivi Visvanathan at UCLH and UCL. This is also an editorial. It's a very short read, again, at 2 pages. So they look to the future of prostate cancer and prostate cancer diagnostics and imaging. This is authors with a serious pedigree. Their studies have heralded a revolution in prostate cancer diagnosis, whereby now MRI and MRI-guided biopsy is a new international standard. They also point out that prostate cancer diagnosis is set to double in the next 20 years. There's already a shortage of radiologists to read all these MRIs, and it's predicted that there'll be a 40% shortage by 2027. So prompt international solutions are required. Enter possibly artificial intelligence. And of course, I think artificial intelligence is a hot topic in all sectors across the entire world. So with regards to prostate cancer MRI diagnostics, there's been some promising studies to date, but all are either single site or retrospective. And they introduce Paradigm, which could be an international game-changing trial. 500 patients, 20 centres international, paired within patient study, with the radiologist blinded to the AI read, which happens separately, and then they do a combined read where the radiologist has access to the artificial intelligence read as well. They're keen to point out that this should be across not just different countries, but different MRI vendors, They'll have the primary outcome will be Gleason grade 3+4 and above. Biopsies will be performed according to local practice, so pragmatic in that regard. Recruitment set to begin in Q4 2025. But I was texting Vera about this earlier on today, and he's keen to point out that anybody who's interested, if they're motivated, they'd love to have extra centres on board, with recruitment set to finish in 2027. So watch this space. They've already also received funding from the European Association of Urology Research Foundation. And I think one of the things that I would point out about this is that it's really interesting to see. I mean, there must be heaps of companies involved in AI and machine learning, but this is going to be an investigator-led study, and whether this will have the ability, like this group of authors have done in the past, to really stimulate practice change and integration of AI into routine clinical practice. Maybe this is the kind of the scene is set for it. They're also keen to point out that this is not to replace radiologists. This is to help radiologists and work synergistically with the radiologists. There's more details in the paper.
There's also more details on an episode of GU Cast that we just posted yesterday, because when I was in London recently, I caught up with Viru and the Paradigm team and the Compass team, and they're all dovetailing into Burst Urology that Nikita was very involved with. So Viru's had an excellent track record of this, generating collaborative research projects from often young investigators, medical students even. And so him and his team speak in some detail about the Paradigm project. So yeah, very nice. Nikita.
Yeah, I mean, AI is taking over clearly, so hopefully it can make lots of things easier for us. And I saw that interview, actually, very good. They're very enthusiastic, very promising medical students.
Yeah.
Much brighter than I was at their stage. So well done to Viru for finding the best talent in the field always.
Always. Yeah. Fantastic. Well, Eoin, thank you very much for that. That was superb. We'll have him back again next month, Nikita, but it's 3. You're only allowed to pick 3. So, authors are so happy when they get into European urology, and maybe some of them will they'll get a spotlight video. That's another little nice niche we have, these beautiful animated videos, or they'll get called up on the podcast, or they'll make Eoin's list. So he's open to bribes. If you get your paper published, talk to him and you'll get at least highlighted on the European Urology podcast. So Nikita, that's it for us for July. Again, it was nice to talk at the start about the new impact factors and onwards and upwards. I suppose the team are certainly very happy about it, aren't they?
Yeah, absolutely. I mean, the impact factor of 25 is brilliant, and I can see all of the European Urology family journals have had an upgrade. So that's always nice to see that the hard work is paying off, and hopefully we continue to attract the best work in the field in this journal family.
Absolutely. And we'll continue to showcase it here on the European Urology Podcast. So that's all we have time for in the July edition. Please do subscribe and rate and review us, and get in touch if there's anything you'd like us to talk about on the podcast. We're always open to ideas of what else we might entertain listeners and viewers with on the European Urology Podcast. We'll be back next month with the August edition of the European Urology Podcast. Thank you very much.